Good afternoon. I will be mentioning poop 0 times in my talk today. Um, but I'm really excited and honored to have been invited to speak with you today about two of my favorite things, newborn screening and collaboration. Here are my disclosures. For those who don't know me, my name is Lesa Brackbill, and I live in Hershey, Pennsylvania, but I'm originally from Northern California. I've been married to my husband, Brennan, since 2010, and we have 3 children, Victoria and Isaiah and Caleb, who are identical twins. I have a bachelor's in political science, and I just finished my master's in strategic communication in May. Thank you. And I have lobbying experience. I'm an author, I'm an advocate, and I helped start the Leukodystrophy Newborn Screening Action Network in 2020. My daughter, Tori, is the reason I've become an expert in newborn screening advocacy in the United States. It was because of her that I fought over the course of 5 years with 3 different bills to reform newborn screening in Pennsylvania, making our program one of the strongest in the country. It is because of Tori that I persisted in advocating to the Newborn Screening Advisory Board and convinced them to add Krabbe disease, which is what she had, making Pennsylvania the 9th state to begin screening. And it is because of Tori that we identified 4 babies with Krabbe disease in our first 7 months of screening for it, including identical twins born on her birthday. Since she gets the credit, I always like to honor her first. So I was asked to speak not only about what newborn screening is, but also effective newborn screening advocacy, and those go hand in hand because it's challenging to explain effective newborn screening advocacy without first explaining what newborn screening is and how complex the whole system actually is. So we're going to start with that. Newborn screening is so much more than just drops of blood on a piece of paper. So I will talk about what it means to be an effective advocate, why collaboration is everything, and what we expect to see with metachromatic leukodystrophy or MLD newborn screening, because that is going to impact your community. So what is newborn screening? This is something I call newborn screening 101. It's a very short version of the complexity of the system because I want you to be better equipped than I was 9 years ago. To begin, I love this quote from the founder of newborn screening, Dr. Robert Guthrie. He said, "No child should die or suffer disabilities if a simple blood spot can prevent it." Newborn screening began 60 years ago with a metabolic condition known as PKU. In the years since, dozens of conditions have been added to state panels and to the Federal Recommended Uniform Screening Panel, or RUSP. It's important to note that newborn screening is not just a test, it is a system. It starts with scientists like Dr. Gelb, who develop the actual assays that can detect disorders, lab technicians who run the tests, state newborn screening programs that manage this entire system, geneticists, genetic counselors, clinicians, and specialists who deliver the news, treat the patients, and others. But it's also not just one test, it's 3. It involves the dried blood spot test that we're all familiar with, a pulse ox screening, and a hearing test. The dried blood spot aspect of newborn screening takes place 24 to 48 hours after birth, and that timing is extremely important because if it is done earlier or later than that, the results can be inaccurate. The baby's heel is pricked and blood is put onto filter paper as shown in this picture, which is actually from one of my twins. I made them do the newborn screening in the room with me so that I could take pictures. They thought it was weird, but it's okay. So then the blood spots are sent to a lab for analysis. So what are they looking for? Using Krabbe disease, which is what I'm most familiar with as an example, the test looks for low Galce enzyme levels, and if those are detected, they do a second test for elevated cytosine, which is a toxin that destroys the myelin. The MLD example is that they're looking for elevated sulfatide levels, ARSA activity, and then related gene mutations. As is everything in the United States, each state operates its newborn screening system very differently. Some states have their own lab in state, but several states either use another state's newborn screening lab or they use Revity, which is a private lab to process their newborn screening. Many states also screen for a different number of conditions, though the disparity is not as bad as it looks, and we'll talk about that in a minute. Many states now have RUSP alignment laws, which help conditions be added more quickly, but a majority of states still do not. And of course, every state funds their newborn screening program a little differently. So one way that conditions are added in 48 states are through newborn screening advisory boards. You may be surprised to know that in 48 states, you do not need a law to add a condition to newborn screening panels. So these advisory boards are typically composed of geneticists, pediatricians, specialists, and parent advocates. As I mentioned, 48 states have them, but the authority differs from state to state. Are you seeing a pattern here? So some states like Pennsylvania, because of me, our advisory board has the direct power to add conditions. What they say goes. Other states still have to recommend to their state secretary of health, who can then decide to say no. So what is the RUSP? As I mentioned, it's the Federal Recommended Uniform Screening Panel, and I want to talk about what it is and what it isn't. So in 2002, some states were only screening for about 4 conditions, while others were screening for 50. So in 2005, the American College of Medical Genetics and Genomics was tasked with developing newborn screening guidelines, and they ultimately chose 29 conditions to be put on the original recommended panel. That list was published in 2005, and in 2010, it officially became known as the RUSP, and it became the nation's minimum newborn screening standard. Its mission was to increase uniformity in screening between states, which has largely been successful, but there's always room for improvement. And it's important to note that this is a recommended, not required panel. States can still choose to not screen for what is added at the federal level. Another acronym you will hear in relation to newborn screening and the RUSP is ACHDNC, which stands for the Advisory Committee on Heritable Disorders in Newborns and Children, which is why we use the acronym, because it's a mouthful. It was formed in 2003 as part of this same process to try to increase uniformity between states. They meet 4 times a year to review evidence from nomination packages. The MLD one was just submitted last month, and they're actually going to be looking at it next week. They recommend conditions to the Secretary of Health for addition to the RUSP, and the Secretary ultimately makes those decisions. But it's important to note that since 2015, only 6 conditions have been added to the RUSP. This is not the best process. Additionally, it takes up to a decade for every state to implement screening for new RUSP conditions. As an example, X-linked adrenal leukodystrophy was added to the RUSP in 2016, and there are still states not screening for it. That's why the Every Life Foundation began introducing what they call RUSP alignment legislation to not only require that states add RUSP conditions within a specified time frame, but also to equip those state programs with the funding required to make that happen. So far, I think 13 states, because I forgot that Tennessee recently added one. So, okay, yep. So I forgot. I have 6-year-old twins, so yes, I will fix this for the next time I present this. So thank you. You're right. Louisiana did. We just had some questions about their bill. But the important thing to note about these laws is even though it's great, not all of these are well written, and some of them are overly restrictive, like California and Arkansas. So one of the things I was really surprised to learn as a parent advocate is that there are strong ethics behind which conditions should be added and should not be added to newborn screening panels. And I'm only going to highlight a couple of these things, but this is the original Wilson and Youngner criteria has been used for a very long time. But essentially, states want to know that there's an effective test with few false positives. They want to know that there's an effective treatment, and they want to know that the benefits of screening should outweigh the harm. This matters because as we go through what we've developed as the 3 pillars of newborn screening advocacy, this will be helpful for context. I mentioned earlier that the disparity between states when it comes to the number of their conditions on their newborn screening panel isn't as extreme as it seems, and I wanted to mention that here because this is one of my biggest pet peeves. Why do some states say they screen for 80 conditions while others say they only screen for 35? The short answer is they actually don't screen for that many different conditions. When you look at lists of the states, it looks like these ranges are drastic, but here's what you need to know. States count the conditions on their panels differently. So there are core conditions. There are 38 on the RUSP, for example. Then there are secondary conditions, which are ones that can incidentally be picked up when they're looking for the core. MSD is an example with MLD and MPS II. In addition, some states add non-RUSP conditions, And then there are some conditions that they will add every possible subset of that condition to make it look like they screen for a lot of conditions. I know Missouri is another example. They claim 77. And so this has become actually a really big problem even in the advocacy community. And I was very excited to be invited to join the Association of Public Health Laboratories committee to work on this. So we will be releasing our recommendations in the near future. So you may be wondering, why don't states just screen for everything? Like, why can't they screen so that parents will know that their child potentially has this condition? And it may surprise you that it's usually not just because they don't want to or that they are against it. There are so many different parts to the newborn screening system, and each state faces its own hurdles and barriers for expansion. So some of those hurdles are, as I mentioned earlier, 12 states use another state's lab instead of having their own. And a great example of this is Iowa. So Iowa does the newborn screening for Alaska and the Dakotas, in addition to Iowa. So that means that if you live in one of those states that uses Iowa, you cannot add your condition until Iowa's already screening for it. Another example of this is New Mexico. They've had a law in place to screen for Krabbe disease for over a decade, but they outsourced their newborn screening to Oregon. So until Oregon is screening for it, they can't do anything about it. So there are advantages to this method, like less cost to add a condition. You don't have to hire more staff or buy another mass spectrometer, and those are about $500,000. But there's obviously major disadvantages because you have to wait on the other states. And states like Massachusetts, which does almost all of New England, they are pretty slow to add conditions. For states using Revity, which is a private lab, this is a huge advantage because Revity is one of the companies that develops newborn screening assays and reagents and gets them FDA approved to sell to state labs. They can screen for so many conditions. They actually are ready to screen for MLD right now. So because of that, we can approach the states that are already using Revity and say, hey, they're ready, they can do this, you can add it, why don't you talk to them about it? We can also approach those states about screening for Krabbe disease and the other LSDs because those states already have those assays available to them. It's almost as easy as just turning on a switch on their computer, almost as easy. So we can do that. As I mentioned earlier, several states have adopted these RUSP alignment laws that require them to begin screening for conditions on the RUSP within 2 to 3 years. And these are great. But some of the states that have adopted these have language in place that is interpreted to mean that they can only add RUSP conditions. California is an example of this, my home state. Their 2012 law inadvertently prevented innovation and advocacy efforts because it does not allow for non-RUSP conditions. So because of what we saw happen in California, when I was drafting the legislation in Pennsylvania with my senator, we added the line that specifically gave authority to our newborn screening board to add non-RUSP conditions as they are deemed ready. Conditions become more widely adopted when a few states are willing to take on the challenge and be first. That's where the assays are perfected and the data is generated. We have to ensure that anything we attempt with moving MLD and MSD forward allows for that, because we can learn from what other states have done well and where they've missed the mark. But usually it comes down to funding, just like everything in this world, but especially in rare disease. That is why in Pennsylvania, my work sought to take the legislature out of the equation entirely, and we succeeded. And I know this wouldn't work in every state, but because insurance is federally mandated to pay for newborn screening, we were able to shift the funding to insurance through the hospital bundling. It's more complicated than I'm making it sound, but it works. So now we don't have to go and ask politicians for money every time we want to add a condition. And I love that. Because newborn screening costs a lot of money. Remember that they have to have employees to do these tests and to do the follow-up. They have to buy mass spectrometers, which, as I mentioned, are at least $500,000. They have to pay electricity bills. Like, it costs money. Texas even had to literally expand the size of their lab to begin screening for Pompe and MPS 1. It's just complicated. So these are some of the major hurdles that the states are facing, in addition to the fact that the federal law, the Newborn Screening Saves Lives Reauthorization Act, has yet to be renewed. That varies per state. If the cost per child screened, it really varies. In Pennsylvania, I want to say it's still in like the 70s, but there are some states that charge over $200 for the newborn screening. So, what can we expect to see with universal screening for metachromatic leukodystrophy? Before we talk about my expectations for MLD newborn screening, I want to talk about why it will be essential for the MSD community to partner with MLD when it comes to newborn screening advocacy. The current reality for MSD is that there is no approved treatment. Because of that and because of its ultra-rare incidence rate, it is unlikely to be added to the RUSP on its own yet. That leaves us with a difficult path to diagnosis, which I know is not ideal. However, because MSD can be identified when looking for MLD, and the reality for MLD is incredibly bright because we have an FDA-approved treatment, we have an assay, and we've already submitted our RUSP application, it means that a newborn screening advocacy partnership is mutually beneficial and essential and honestly easier. And that's what we want, right? We want something in our lives to be a little bit easier. So this is the anticipated timeline that I put together last year for what we expect for MLD. It's based on an official recommendation from the ACHD&C next May. They have 9 months once they decide to start evaluating a condition, so that clock should start next week, which means official addition to the RUSP by the end of 2025. I don't have time to go into every state in this presentation, but I do have all this available on the LDMBS website. And this is what I think we can expect to see. It is a very ambitious goal, but we believe we could see every state screening for MLD by 2029. I developed the strategic plans for both MLD and Krabbe disease newborn screening expansion using my beloved spreadsheet of data that I began collecting in April of 2020. This is publicly available too. However, as I was working to help fellow parent advocates better understand all of this, I realized that this was not accessible to all people. Surprisingly, not everybody loves spreadsheets. Not everybody can look at the spreadsheet and say, ah, yes, this is exactly what I need to do in my state. And even for me, as familiar as I am with all of this, and I can tell you most of this stuff off the top of my head, I knew I needed to make something out of this data. And this is also how I procrastinated on a paper last year for grad school. This is where the dopamine was. So more than anything, though, I wanted to help provide hope and clarity to fellow parent advocates in the leukodystrophy space. Because all of this is extremely complex, it's overwhelming, and it has taken me years to fully understand all of this. So I want to help you understand it as much as you would like to. So for those who prefer visuals, here is a map of the expected implementation for MLD, and I love how big this screen is because you can actually see it. So the states in blue we anticipate will begin screening between 24 and 26. The states in pink we think 27. Teal is 28 and white is 29. Of course, this can all change, and I really hope more of them are in the blue and teal, or pink, blue and pink, but we will have to wait and see. So this is a brief look at the strategic plan that I created for MLD, and the QR code will take you to that document if you would like. You'll see pages like this. So I took that spreadsheet and I analyzed all of the data, and I looked at the different categories of states. So the ones with RUSP alignment laws, the ones with condition nomination processes that are publicly available, the states with newborn screening advisory boards, the ones that have all three of those. And that helped me prioritize and visualize what we can expect. And the end of the plan is a chart showing each state and the route we should take, as well as the expected implementation date. Again, there's that. And then also we have so many other resources at ldmbs.org if you would like to visit and take advantage of those. All right, we're going to switch gears now to what does it mean to be an effective advocate? I have spent 9 years now learning all of this the hard way. Through my advocacy, through my observations, I have seen advocacy done well, and I've seen it be disastrous, honestly, even in my own early efforts. So I've taken the lessons that I've learned and I've incorporated this into my presentation today, but I want to make it clear that I have not perfected this in any way. No one has, but by listening and collaborating, I have seen success, and you can too. As I wrote once, the depth of my love for my daughter is not measured by the number of tears I have cried, but rather by the life I choose to live in her absence. And you have that choice to make as well, though it will look different from person to person. I choose to further Tori's legacy through newborn screening advocacy and through advocacy done well. When I first started advocating, I had no idea how much I didn't know. I knew that newborn screening could have saved my daughter's life, and that passion blinded me to the realities and complexities of the situation. Along the way, I learned how to listen to understand, and that changed everything. What I have learned is that how we accomplish the legacies we leave for our children matters even more than the legacy itself. We have a choice to make. We can go in with rocks and fire and anger, or we can go in with a willingness to be kind and work with the established processes. Advocacy is how I continue to be Tori's mom. It is her greatest legacy, and I want it to be established with kindness, respect, and collaboration. I believe that being an effective advocate involves several components. The first is being willing to learn as much as we can about our disease, our state, and our story. We must be willing to listen to understand, to collaborate, and in collaboration, recognize that we all have different gifts, expertise, and we will go so much farther by working together. We must communicate well, which also includes listening. We have to be willing to embrace flexibility, which is not fun. But most importantly, we must be willing to take action, whatever that looks like for us as individuals. So the 3 pillars of the newborn screening advocacy philosophy that LDNBS developed are to know your disease, know your state, and know your story in this order, which is purposeful. First, it's most important to know your disease. It's important to know that not all leukodystrophies have a newborn screening assay or test. Not all leukodystrophies have a treatment. And the lack of those 2 things makes newborn screening for a condition impossible, and some would say unethical. It is important to know as much as possible about the condition for which you are advocating before you start. Knowing everything you can about your condition's assay and treatment will help you advocate effectively. The next step is to know your state. It's important to know how your state operates, who the decision makers are, if they have a newborn screening advisory board, 48 states do, if they have a nomination form to fill out, and if there are any other issues preventing the addition of your condition. Because only 2 states require legislation, my experience has taught me that the best way is to go through the public health system. Use the newborn screening advisory boards and the state labs because they are the medical experts. They understand the needs not only of these children, but of the newborn screening program. And honestly, it's a lot easier if you use politics, if you leave politics out of it. I watched this play out in Pennsylvania as my nonpartisan newborn screening bill became partisan because of the party affiliation of the sponsor. That is why I so strongly believe that politicians should not dictate health policy. The medical community should. The last pillar is knowing your story because that's the easiest part. You have lived this. And most of us could talk for hours about our child, our experience, and our trauma because our child wasn't screened at birth. But most decision makers don't have that much time, so you will need to develop a pitch, which is a shorter version that packs in all of the necessary information. And learning about your disease and your state helps you do this. As you're learning, look for known or potential obstacles to adding your condition. Consider what will speak their language. Sometimes it's comparing to other states, like with data and statistics. Sometimes it's appealing to the ethical or moral aspects of screening. But almost always, if you can tell them that they will somehow save money while saving lives, that can help get the job done. But I also want to point out that your only job as an advocate is to point out the problem. Your job is not to figure out, like I did, don't do what I did. Don't figure out everything that's broken with the system and try to fix it unless that's something you want to do. The most impactful thing you can do is bring your story, bring the problem to the attention of those who can fix it and let them do the rest. While your story is incredibly impactful, sometimes our stories are not enough, as this quote at the top says. Without data, you're just another person with an opinion. That's why we ordered these pillars of advocacy as we did, because more than once when I testified, much of the data that was given in opposition to screening for Krabbe disease wasn't accurate. So thankfully, I have my own published data ready to counter what they said. As much as we want our stories alone to be powerful enough to make our case, having the data gives us credibility and helps us establish facts, not just opinions. And I love this quote from Brené Brown as well. It captures why it takes both, because data needs a soul. Numbers can be boring to some people, but if you are able to show the direct impact of that data, it can make all the difference in the world. The most important lesson that I've learned, though, is that advocacy requires more listening than speaking. If we want decision makers to support us and listen to us, we have to be willing to listen to them. We should never assume we know everything and that stakeholders have nothing to offer us. As I said, I have been here. Effective advocates listen to understand. Well, what does that mean? It requires humility, a willingness to be wrong, and the ability to change one's mind when new information is obtained. It humanizes those on the other side and helps us better understand the motivations behind their stance. Of all the ways that I have changed in the past 10 years since Tori was born, the greatest impact has been from listening to understand. One of my favorite teachers says frequently, listening to understand doesn't obligate you to agree, but it often helps you to see why the other side feels the way that they do, and you may indeed end up changing your mind. That has been my advocacy story. My success in reforming the newborn screening system here in Pennsylvania happened because I listened and I sought to understand. Listening to understand truly did change my life, even though it sounds dramatic. But in 2016, 3 weeks after Tori died from Krabbe disease, I attended my first newborn screening advisory board meeting. I was grieving, I was angry, and I had no idea how any of this worked. That first meeting was not a pleasant experience. It was quite terrible, but I kept going. To this day, I still go. I kept learning, and between the time our first bill was introduced in 2017 until the time our third and final bill was signed almost five years later, the bill had changed because we listened. I recognized that I didn't fully understand how any of this worked in Pennsylvania. I didn't understand the impact that what we were trying to do would have, so I listened, and that's how we were able to make Pennsylvania's screening program one of the strongest in the country, during COVID, I might add. Why does this keep moving? I'm sorry. Okay. Now Pennsylvania is the only state currently screening for all RUSP conditions. We can add conditions in 6 months. And as I mentioned, we've been screening for Krabbe disease since 2021. So had I continued in my anger, which admittedly felt good, none of this would have been accomplished. I would not have continued to be involved in seeing meaningful change happen in Pennsylvania, and I probably wouldn't be speaking to you here now. Anger feels good in the moment, but in the long run, kindness wins. Effective advocates communicate. As I said earlier, my master's is in strategic communication, so I am passionate about effective communication. It takes practice, and the previous step of listening to understand really helps with our own communication while advocating. So what does this look like? It looks like communicating and operating in our advocacy transparently, constructively, collaboratively, which also means avoiding the duplication of efforts and coordinating those efforts, but also ethically. What do I mean by this? This means not blindsiding the public health labs by going in, using legislation to mandate that they test for something. There are so many reasons why legislative mandate is not the most ethical way to do this. But I also say that because I've seen so many well-intended bills go wrong. And so I just encourage you to work within the established processes. Most importantly, effective advocates collaborate. Collaboration goes beyond families working together in their state, advocacy groups choosing unity and not competition. It means collaboration with all relevant stakeholders. It's essential. If we aren't communicating and collaborating well, not only will our advocacy take longer, but it may have unintended consequences. For the MSD community, as I said before, I believe your best path forward is to join us with the MLD community rather than going it alone. Our conditions are related, our patient groups are small, and willing advocates are few. And so we need each other to succeed. And like I said, it'll be a lot easier this way because we need to work smarter, not harder. But collaboration has other benefits as well. Advocacy can be very difficult work, especially for those of us who have lost children or loved ones to these diseases. Telling our stories over and over again, reliving the most difficult parts of our lives can be incredibly traumatic. I heard the phrase compounded trauma recently, and I believe that that's something we should all be aware of in advocacy because every time you relive that trauma, it can be compounded. That's one reason why we've been creating one-pagers for MLD families that are specific to their state and how their state operates. That way their story is there for the decision makers to read, they can leave it with them, and they don't have to actually vocally tell their story unless they feel like they are in a good place to do so. Also, many advocates are still active caregivers with limited time and energy, so it just makes sense to work together so that we can alleviate the burden on each of us. This one is the hardest, but we must embrace flexibility. And this goes along with listening to understand and all the other components I mentioned really. As we get started in a state and as we learn more, we may realize that there's a better approach, and it's important to go with the flow as much as I really like to have a plan. We need to be prepared also for us to change for the better if we allow it to happen. But the journey is going to be unexpected, frustrating, and rewarding. Being flexible is an absolute requirement. As I mentioned many times about listening, we have to listen to the stakeholders, whether that's the hospitals, the insurance companies, whoever those stakeholders may be willing to make adjustments, change tactics from state to state, and all of this requires a willingness to be flexible. Flexibility looks like welcoming everyone to the table while honoring and respecting the experience and expertise each one brings. Plans may need to be changed based on who is there, what they know, and what we discover as we work. And as we all know, collaboration requires flexibility and a dedication to those collaborative efforts. We are all different, we have unique perspectives, and it can be a serious challenge to work together, especially when we bring grief into the mix, but it's a requirement in effective advocacy. And all of these come from observations I've seen in the rare disease world. And finally, effective advocates take action. But before we talk about taking action, I want to make an important observation. Sometimes doing something just for the sake of doing something does more harm than doing nothing. We don't want to break the system just to get our way. And I have seen this happen. And like I said, it's always well-intentioned, but it's something we need to be very aware of. States have paved a road for us to take to see these conditions added. Just because there are potholes and detours along the way doesn't mean that we go off-roading. It just may mean that we need to help fill the potholes. This can look like helping to pass RUSP alignment legislation in your state, working alongside the newborn screening program to strengthen it, whatever that may mean. Off-roading may seem fun, but it often does damage that is difficult to repair. So let's be effective in our advocacy by staying on the road. To use another illustration, we do not operate in a vacuum. So we need to consider where the dominoes may fall because of the actions that we take. Good intentions can yield bad results. A great example of this was a newborn screening bill in Ohio to add Krabbe disease. The passionate and well-intentioned family worked with their legislator to mandate screening for Krabbe disease. As it was working its way through the process, legislators removed the ability to do second-tier testing, and they just recently fixed that 8 years later. As a result, Ohio had so many false positives, which means so many families unnecessarily traumatized. Good intentions, wrong process, bad results. And it probably feels good to use legislative mandate to add a condition because it's your way of basically telling them, like, you will do this because of what you have lost. But it's so important that we don't use our pain or grief as a weapon. We need to use it as a tool to make an impact, perhaps even beyond adding our desired condition. If you are wanting to begin advocating for newborn screening, the first thing I'd encourage you to do is to have a conversation, whether that is with me, with Sarah, with your newborn screening advisory board, or the newborn screening director, and that's how you can contact them. babiesfirsttest.org has all that, or you can Google that information for your state, but have a conversation because listening leads to learning. Ask them what hurdles your state would face if they were to add your condition, or in our case, we would say you should definitely just talk to them about MLD. And are these issues that could be fixed or need to be fixed by advocacy groups? To give you a brief a brief example of what you could say, you could just tell them a brief part of your story. So like I would say, my name is Lesa Brackbill. My daughter had Krabbe disease and died because she wasn't screened for it at birth. I'm calling today to learn more about how this state adds conditions and what hurdles you may be up against in adding Krabbe disease to your newborn screening panel. It doesn't have to be extensive. You do not have to be an expert to speak up. But I want to emphasize that I understand that not everybody is in a position to advocate, and that is okay. We must respect each other's journey and recognize that the trauma that can come from telling our stories repeatedly can be too much for some. As you can, though, here are some steps you can take in your state to gather intel, which you should definitely report back to me, and make progress. But with all of these, I just want to remind you to always be kind. Being firm is okay. Being blunt is great, but do it with kindness and respect. Because remember, you want these decision makers on your team. We want them on our team. So here's some ideas. You can attend your newborn screening advisory board meetings. All states are required to somehow publicly post their information, though of course they all do it differently and some make it very difficult to find, so I can help you with that if you would like. Learn who is on the board to represent conditions like leukodystrophies, and speak with them about the importance of telling parents about an MSD diagnosis, or just adding MLD. Because not all states are going to automatically report out MSD once MLD is added. Build relationships with anyone that you can. That can be your state legislators or their staffers, because they do all the work anyway, the newborn screening director, advisory board, etc. So again, even though we don't advise legislative mandate for adding conditions, your elected officials often know which buttons to push to make things happen. Find other rare disease groups in your state and learn from them. Find groups that have a common goal and build a coalition. Like your state's Rare Disease Advisory Council, if your state has one, would be a great place to start. You can also create or distribute one-pagers or other resources. Determine what has already been done in your state by other newborn screening conditions. This is where you can learn the most. Look at the ones that have already been successful and have a conversation. How did they do this? What lessons did they learn? What would they do differently the next time? And along with that, always examine the playing field. Don't duplicate efforts when you could be multiplying them. And part of that is because advisory boards and other decision makers get really irritated when they are approached by separate groups about the same thing. That goes with the FDA too, the ACHDNC. They don't like to see that there is not cohesion in the advocacy community. So we must work together even if it's challenging. So in summary, I believe that being an effective advocate involves being willing to learn as much as we can about our disease, our state, and our story, listening to understand, collaborating, recognizing that we all have different gifts and expertise, communicating with humility, respect, and kindness, embracing flexibility to do what is best in each state, and to take action however we can with whatever time and energy you can share. I believe that the data and research show that we could see every state screening for MLD by 2029. 5 years sounds like a long time, but that's actually incredibly short in the newborn screening world. And if we can make it happen, we are going to be so, so excited. But it's going to take all of us, and not just families. It takes the scientists, the clinicians, the advocacy groups, and decision makers to make this a reality. I'm so grateful for the expertise in this room, because we are all dedicated to seeing fewer children dying from terrible diseases like MSD and like Krabbe disease. Some of us did not have the choice to be here, so we are forever grateful to those who did make that choice. While I would do anything to have my daughter here today as a healthy 10-year-old girl, I know that this life of newborn screening advocacy was always supposed to be my story. And it is all because of her and our great loss that I advocate. Krabbe stole so much from her. It stole her smile, her voice, her big, beautiful eyes, and ultimately her life. And I will do everything that I can to prevent other parents from experiencing the breathtaking grief that comes with a diagnosis without hope, because that's what newborn screening brings. It brings diagnosis with hope, not despair, an opportunity to treat their child instead of bury them. So thank you so much for your time today, and I'm happy to answer questions today or at any other time.
Be a 50-year-old person with MSD that's just blind. So I imagine that's going to build the story that, well, there might be people diagnosed that never get the disease. So we're giving them the information that they don't need. How do you explain that to the people who are making the decision?
I would never mention the prevalence of late onset cases.
They don't research that or look it up themselves, or?
I mean, they may, but like when I talk about Krabbe disease or even MLD, I don't talk about late, like juvenile or adult onset, because that's not the goal of newborn screening. The goal is to catch the kids that need the treatment immediately, like early in life. And so I'm not telling you to omit information, but I kind of am. And that is just a strategic standpoint because, like with Pompe disease, there's still controversy about Pompe disease because most of the cases are ending up being late onset.
Yeah.
So we just have to be very careful.
Well, will they bring that up as like, well, will this be like Pompeii? Like we're,
I guess it would be helpful to know the data then, I guess. Like, are the majority of your cases requiring early treatment? But then to also point out that, like, that's, newborn screening is just the screen. It's not diagnosis. That's the clinician's job. So you can also just kind of push it off on that.
right. I mean, as a mother, I would say like if you find one child, that's worth all the risk.
Oh, I know. I know it absolutely is. They just don't always see it that way. Yes, look at natural history data because we're so grateful that people like these two wonderful doctors have been publishing like crazy about all of these conditions to make our life easier. When I first started in 2016, there was almost nothing published about Krabbe disease. So I'm up there telling these doctors as just a parent, what I was hearing at symposiums and what I was hearing and what I knew, but they're like, it's not published. So you take advantage of all of the publications that we have. Nobody would vote for me because I'm now nonpartisan because of all of this. Well, thank you all. And like I said, I'm really excited about working with your community and with MLD because I think we're going to move mountains together.
Thank you. Okay, so I'm willing to take suggestions from the floor for this next one. Oh, my phone. Okay, it's on the floor. So we had originally planned for this next one to be a panel, because then we quickly realized that the number of people on the panel would be greater than the number of people in the audience, and that might be a little bit strange. So what I've done is I've changed the questions to be more for group discussion because I do think everyone, all families have a voice to contribute to these questions and things to be learned from, regardless of where you are in your journey or your form. What I would love is, I was originally thinking we would all gather around these two very small tables at the front. However, I think that might also be awkward. So, do you have any recommendations? My constraints are we would like there to be a couple of mics we can pass around because we are recording it for families who can't be here today. So we can't really go to another place because I think of AV limitations to get said recording. But I want you guys to be able to like see each other, interact, have it be a bit more intimate than me running around with a microphone for, that's kind of what I was thinking. Sarah? That's kind of what I was thinking, but also know that there's other people with really good ideas, so I wanted to open it up. Yeah, as long as you guys don't mind a bar in between. Okay, if you guys wouldn't mind just kind of gathering, then that'd be great. Thank you.